Good morning, everybody. So I will explain to you the different steps we took to go from bench to bedside for hematopoietic stem cell gene therapy for cystinosis, and I will also present the mechanism of action. So this is my disclosure. All right, so quickly, what is cystinosis? It's part of a lysosomal storage disorder, and it's an autosomal recessive with an incidence of 1 to 100,000. So the gene is called CTNS, and it's ubiquitously expressed. And it's encoded a transmembrane protein localized into the lysosome membrane, and it's a transporter of cysteine from the lysosome to the cytoplasm. So in patient, mutation or deletion of a gene lead to a non-functional protein, and the cysteine stay trapped into the lysosome, creating these crystals that are very characteristic of a disease. But as I said, the gene is expressed in every single tissue, so it leads to a multi-systemic disorder. And so the patient develop a very early kidney disorder, but also eye defect, neurological defect, myopathy, diabetes, just name it. So the treatment that exists so far, it's called cysteamine, and it's a demanding treatment that has to be taken every 6 hours, very severe side effect, but the most important is that it's only delay the progression of the disease, and the patient still die in early adulthood. So there is a pressing need to find another treatment, but when I started to work on this disease many years ago, I didn't realize that this was a very challenging disease for gene therapy, because it's expressed in every single tissue, but also because the protein is non-secreted. So it's not supposed to be secreted and recaptured by the adjacent cells. So what I decided to take as an approach was to use bone marrow stem cells. We'll just show the data on hematopoietic stem cells, but we actually tried the whole bone marrow, the mesenchymal stem cells, and hematopoietic stem cells. And against all odds, the hematopoietic stem cells was the one that worked the best. So as a proof of concept before going to any gene therapy, we used wild-type bone marrow stem cells, hematopoietic stem cells from GFP transgenic mice, and we transplanted them in lethally irrigated cystinotic mice. And I have to say that the cystinosis mouse model recapitulates pretty well the disease. And so we have seen a very abundant bone marrow-derived cells in every single tissue we tested. And this correlated with a dramatic decrease of the whole content of cysteine in every single tissue. And the decrease was going from 50% to 90%. So it was a really dramatic effect of the stem cells. And we also showed that this led to a long-term preservation of tissue when we were transplanting the mice at 2 months, and looked at the tissue more than a year after. We get a preservation. So in the bottom, you can see a kidney from a treated mice, and only focal anomalies could be seen, and the kidney function was normal as compared to non-treated mice. We also observed in the eye, in the eye treated, so I call that high because it was a high engraftment, there was most total clearance of the cysteine crystals in the cornea as compared to non-treated mice, as well as a preservation of the cornea and its function of the eye. And finally, we also studied the thyroid with our collaborator Pierre Courtois, and we also show a rescue of the thyroid function with a decrease of the thyroid stimulating hormone as compared to non-treated mice in pink. And again, the thyroid tissue was mostly preserved with only focal anomalies. So the impact of hematopoietic stem cells was very impressive, and again, it was very surprising because it's hematopoietic stem cells, the protein is non-secreted, so it was not expected at the time. So, of course, the question we always had was, how do you explain this effect of hematopoietic stem cells? So the first question was, what do the hematopoietic stem cells become when they engraft into the tissue? And at the time, I really thought it would be a fusion with the tissue cells that would lead to their preservation. But we were very surprised to see that the cells were not fusing at all, and was only macrophages or macroglia into the brain. And so it was really difficult to explain, again, not in the context of non-secreted protein, how macrophages could lead to a long-term tissue repair. So even in this context, we were thinking that somehow the protein gets transferred from the macrophages to the tissue cells. So we did some in vitro study, and again, I will make a long story short, but what we've seen is that when we co-culture the macrophage with disease cells, we indeed add a decrease of cystine into the disease cells. So somehow the protein gets transferred. And we showed that it was only when the cells were co-cultured together. So they clearly needed like a contact between cells somehow. And there was something very striking when you were looking at the plate. There was a lot of membrane protrusion going from the macrophages to the fibroblast. And it was so many that we thought that couldn't be a coincidence, so we went back to the literature and we found that in 2004 there was this paper describing membrane protrusion called tunneling nanotubes. And these tubes are involved into intercellular trafficking of organelles, and including lysosomes. So we're thinking maybe the lysosomes themselves could be transferred from the macrophage to the disease cells. So to test this hypothesis, we use a lentivirus vector expressing cystinosis in GFP and transduce the macrophages. And I don't know if you see well, but we could see that the lysosomes were migrating towards within this tunneling nanotube from the macrophages to the disease cells. And we did a lot of study to really characterize these vesicles, and we characterize them as lysosomes. So we went back to in vivo to prove if this was true also in vivo. And in the kidney, so we studied the kidney in particular because, first of all, it's the primary tissue that was impacted, but also there is this very particular structure called proximal tubules. And the proximal tubules are surrounded by a basement membrane that is supposed to be impermeable. And the proximal tubular cells are the first one to die. But when we transplanted the mice with the stem cells, the macrophages were always outside these tubes, so never inside, but somehow the proximal tubular cells inside were surviving. So what we have seen is actually the macrophage in vivo did indeed create this tubular protrusion, and not only they were doing that, but they also were able to cross this basement membrane. So we saw the same thing in the cornea and in the thyroid. And finally, what we've shown is that if we use red hematopoietic stem cells and transfuse them with cystinosis in GFP and transplant no-color mice, you see, or again, around these tubes, that the bone marrow-derived cells that are in red express the fusion protein, but you could clearly see also a transfer of protein inside the proximal tubular cells, and which we know account for now the long-term preservation of these cells. So the study of this mechanism of action, showing that the macrophage play a critical role into the beneficial effect of hematopoietic stem cell transplantation, led us to study a particular mutation, which is the most common mutation in cystinosis. And it's a 57 kb deletion. And why we got interested into that is because this deletion not only remove the CTNS gene, but also the CALC gene, which is also called SHPK. And as a bad coincidence, SHPK is obviously involved into macrophage polarization and differentiation. So then we were thinking with the approach I will explain to you after using, this autologous stem cell, gene-correcting stem cells. We were now wondering if the patient who have this deletion in as an homozygote state could still beneficiate from autologous transplant. So we created a new mouse model, knockout for SHPK, and transplanted our CTNS mice. And this is our very preliminary data. We just got our small pilot groups. But we showed that the stem cells still engrave into the tissue and lead to the restoration of the expression of a protein. And we had also a dramatic decrease of cystine in all the tissues. So this is very promising. I will show you after the cohort of a patient we will enroll. We will still not enroll the patient who have a homozygote state for the first cohort for the time for us to make sure to get all the data from all the groups we have. But for the second cohort, we think that it will be already okay. So, and just another aspect of the mechanism of action what we showed is that, okay, so if it's working for cystinosis, it should work for other transmembrane protein, lysosomal protein. So with our collaborator Eric Adler at UCSD, we started to work on Danon disease. Danon disease is also a lysosomal disorder, and the protein involved is called LAMP2. And it's a transmembrane protein. And the patient develop a cardiomyopathy and they require heart transplant. And because the LAMP2 is involved into the fusion of the autophagosome with lysosome, then there is an autophagy impairment into these patients. And so we did, again, our proof of concept of stem cell transplantation in the LAMP2 knockout mouse model. And as you see, the mice that are non-treated or the mice receiving the knockout hematopoietic stem cells, you have this very characteristic autophagic vacuole in the heart. And these vacuoles are no longer present when you do the hematopoietic stem cell transplantation. And also, again, what we also saw is that there was a good restoration of a protein, and this could be seen into the LAMP2 Western blot. But importantly, is like we also characterize the cells into the heart, and they, again, are macrophages. But there was something that is really characteristic, is that, I don't know if you see very well, but we could restore the LAMP2 expression not only in the macrophages, but also in the cardiomyocytes of these mice. So now we are in the point of developing the gene therapy approach of Danon using the same approach we are using for cystinosis. So now I'm going to the clinical application of this aspect, but first I want to report a case that has been published very recently, and it was a 16-year-old patient with cystinosis. And he got through allogeneic hematopoietic stem cell transplantation after, based on our work. It was a team in Belgium who did that. And it was from an unrelated donor. And unfortunately, this patient developed right away acute graft versus host disease and stayed in the hospital for more than a year. Then the graft fell, and they retransplanted him with the same cells. And he developed chronic GVHD, and unfortunately the patient died 35 months post-transplantation. But despite this very severe complication, the team was able to show efficacy. So the kidney function was improved, as well as the renal Fanconi syndrome. And the photophobia that was from grade 5, which was very severe, and the patient had to wear sunglasses at home, went to grade 5 to no photophobia at all. So we also think that this will be an important endpoint for our clinical trial. They were also able to show a cystine decrease and cystine crystal decrease in tissues and the expression of a protein in a large number of cells. So this case supports the approach we are using and that we are all here for gene therapy. So it's the ex vivo gene therapy approach. So we'll mobilize the hematopoietic stem cells and do ex vivo transduction with a third generation antivirus vector that was provided by Donald Cohn and is using the same vector in his phase 3 ADA deficiency. So we went to the FDA in 2013 and starting the pharmacotoxicology studies. So I had to establish all the GLP rule into my lab and got the GMP comparable lentivirus vector. And then we started the toxicology study a few years back. And we used SCA1 positive hematopoietic stem cells, transduced them, and put them in primary and secondary mice. The mice that were transplanted in our first in vivo study, we obtained a good average of VCN in all the mice, about 2, that was stable at 6 months. There was also a good vector copy number in all the hematopoietic cell lineage. But what we observed in this first study when we analyzed the data is that there was, unfortunately, very high level of early death before 4 weeks of age. So this, when it's before 4 weeks of age, it's because there was inadequate bone marrow reconstitution. So we had a high rate of death in the test mice as opposed to the control. And also, there was clearly a very low level of white blood cells into the test mice compared to control and wild type. So again, all this was suggesting that there was inadequate bone marrow reconstitution, and it could suggest that something was wrong or toxic with a test article. So we went to corrective action, and we went in vitro and tried to study what could be wrong into this the test article. And so we used wild type in CTNS deficient SCA1 positive cells. And what we've seen, and that was very clear, is that when the polybrin alone with no vector was clearly killing the cells. And there was only about 10% of survival. When we were using polybrin plus the lentivirus vector, then the survival was better, but still very low. I mean, less than 50% as compared to the mock, which didn't see any polybrin. So we don't know the reason, and we want to study that, but there is a clear toxicity effect of a polybrin, which is usually used to improve the efficiency of a transduction, but in our case, the disease cells are very sensitive to the polybrin. So we did a new study protocol, and we didn't use polybrin this time. And then we observe, a really good body, comparable weight in test and control mice. Again, the VCN was about 2 and was stable. And this time, the early death was, as expected, very close to 10%, and also comparable to control. And we did also some safety analysis with vector integration site analysis that was performed by Dr. Bushman, who reported that our lentivirus vector integrate the integration site are very comparable to many other studies that he has as comparison. I'm not showing we also show efficacy data with cysteine decrease in all tissues, and also even decrease of inflammation into the test mice as compared to control, but this data was shown on Tuesday. So we also did the manufacturing development, and this was done with the collaboration of Donald Cohn, because he's going to be the one who will manufacture the stem cell for the clinical trial, so in the GMP room at UCLA. So we tried several protocol with like 2 heat of lentivirus transduction and different MOI. And the one that was the most consistent between healthy and cystinotic and gave the best MOI was a pre-stimulation with MOI 40. So this is what we are going to use for the clinical trial. So we did a technology transfer at UCLA, and with using patient cells, and Don Cohn team got about the same VCN what we got, but you can still see that there is variation from one patient to another. So it will be hard to predict where VCN will have for the clinical trial. And finally, we did a successful large-scale run, and this part was so now complete. And so I don't cite all the toxicology studies we did, but we did also in vitro immortalization assays and many more. We did so the manufacturing development, and we also have a consortium of 14 members and for the clinical aspect, and 12 of them are physicians, because we really want to study all the tissues into the patient. So we did the clinical design and assembled the IND, and we submitted that in November and got approved in December 19, 2018. So the clinical trial will be a one-arm, open-label, single treatment for safety and efficacy study. We will do a GCSF PRXE4 mobilization. We will do an ex vivo transduction. We got the GMP virus vector produced by Canis corneta, and it's already characterized and ready to go. We will have a full medullary ablation using busulfan and a one-time infusion of corrected cells. So the patient, it will be a staggered enrollment with a cohort 1 will be 2 adults, and we will use the protocol we established now. But the cohort 2 will be also 2 adults, but we will have the opportunity to change the protocol depending on the results of the cohort 1. And then if the risk assessment is good, we are planning to get 2 adolescents for the last cohort. So the design of a clinical trial will be as follows. So we will have the leukapheresis product collected at UCSD. We will have a carrier that will bring this product the same day to UCLA. UCLA will do the CD34 isolation and transduction, and they will ship back the frozen product to UCSD, where it will be reinfused. So as I said, it's a safety but also efficacy study. So we will really study all the different clinical complications that we saw into, that we are seeing into the patient, like the kidney, the eye. As I said, the eye, I think, will be one of the main endpoints with as well as the kidney. We will have also muscle strength, neurological defect, and we will follow the VCN and other molecular aspect over time. Some of the endpoints that we are developing will be, some of them are clear objective with measure of cystine into the blood, but also we'll do some rectal biopsy to also measure into some biopsy, because we can get up to 9 biopsies at a time, so we'll be able to do a lot of things with these biopsies. But some also we are developing some exploratory endpoint in the lab to try to measure the crystals with non-invasive way. And so, I also forgot to say that we have the support of UCSD, Sir Malfa Clinic and Sanford, who have 12 beds in the Jacobs Hospital for bone marrow transplant. So this is where the clinical trial will take place. So, as I said, so there is no natural history that exists for cystinosis, and you all know that we need this kind of data for a clinical trial. And so we are starting to do a natural history and to develop some exploratory endpoint. So far we have 29 healthy subjects enrolled and 66 patients. We just got 60 more recently, but we don't have all the medical record yet. So the age range will be between 10 months and 55 years, and the mean age is 15 years. So one of the exploratory endpoints we are developing is a skin confocal microscope. So it's very non-invasive, and we can observe the crystals into the skin of the patient. And this is we developed a new 3D imaging system to be able to reconstitute the 3D image, but also to quantify them. And the preliminary data we have showed that we have, if we check the quantity of crystals in the papillodermis only, we have a very low background in healthy control, and in patient there is a clear accumulation of cystine. So that will be able to be done many times during the course of the clinical trial. And so I just want to finish by acknowledging every all the people in my lab and all the people who worked to have very difficult toxicology studies in particular. We, all the members of the consortium, all our collaborators, Dr. Bushman, Don Cohn. I want to also acknowledge our industry partner, AvroBio, and all the funding, obviously, the Cystinosis Research Foundation, CERM, and NIH. And thank you.
So this is very cool. Congratulations.
Thank you.
Been waiting for a trial like this. So you didn't mention exclusion criteria. So what about kidney transplant? Do you have those patients that you're going to do? Do you have exclusion criteria?
Yes. So kidney transplant will not be an exclusion criteria because, unfortunately, most of the patients are transplanted before the age of 16. But so that's why we, for the adults, for most of the patients, they will already have kidney transplant, and that's why I was saying that our main endpoint, I think, will be the VI, because the kidney might not be, possible to check. But we actually have volunteers so far who have no kidney transplant who are adults, so it's possible that even in the first cohort we will be able to follow the kidney function. But it's not an exclusion criteria because it seems like, according to our expert, if for autologous transplant, it's not, and because also we use busulfan that is not nephrotoxic, it should not be an issue for the transplant.
So there's no exclusion criteria? I mean,
yeah, of course there are exclusion criteria. Okay. But the exclusion criteria are mostly related to bone marrow transplant. Mm-hmm. So of course we need a good healthy function, kidney, thyroid function. Some serology that have to be negative. So, but there is nothing in particular except that the usual bone marrow transplant.
One other quick question. A lot of the older patients get cognitive decline and CNS involvement. Yeah. Did you look in the mice to see whether the bone marrow transplant or the lentivirus was effective in the brain?
Yeah, it does. The cells become microglia. There is a clear decrease of cystine into the brain, and so yeah, and it will be it migrates in the brain and become microglia.
Again, congratulations. So I have maybe you have said already, but I didn't get it. So when you're doing your IND enabling study, how long your tox study? And with your previous study showing the wild biodistribution, so my question is also, when you're doing the IND enabling study, what kind of biodistribution data you have to provide to the FDA? So
the biodistribution was done by checking the CTNS expression in all the tissues. And it was, as expected, we had an expression in all the tissues we tested. And it took us several years to conduct these studies. First of all, because only establishing all the regulation that we had to establish at UCSD, I had to do that from scratch because nobody was doing that before. So it was not only my lab, but all the facility around. So it took us, a few years.
How long your tox study?
I think we started in 2014, something like that. So it was 4 years. And also because we also wasted time with this first study and with because of the toxicity of the polybrine.
Congratulations for an excellent study. I'm here. So the therapeutic effect is from the macrophages. Let's suppose you can supply the patient with peripheral macrophages that have the correct gene. Do you think it can help the patient?
So that's a good question, and we will test that. From my point of view, I think the issue with that is that the cells will not engraft long-term into the tissue. That's my guess. But what we are starting to do is to transplant the hematopoietic stem cell themselves. And the preliminary data we got is a long-term still effect that we have in the eye. But we will try also in parallel to transplant the macrophages. I would expect that it would be a less effect, but I have to try it before I say it.
Yeah. And my second question is, do you consider the eye as part of the CNS or outside the brain?
So, I mean, what we will mostly look at is the cornea in the eye, and we have seen a clear migration of the cells into the cornea. Even if it's vascular, clearly they go into the cornea, and there are a lot of macrophages there, and that's why there is a clearance of the crystals. But, yeah.
So outside the CNS?
Outside, yeah.
Thank you.
Thank you, very good talk. Have you characterized the hematopoietic stem cell compartment and the niche in your cystinosis mice and in patients, and have you transplanted HSCs from patients in xenograft?
So we didn't transplant the stem cells from patient into NSG mice. It was not required by the FDA, so we didn't do it. And especially also, we can get only 100 ml of blood from patients for all the studies we've done. So it's not a large number of cells that we could get, and there was so much to do on the development.
Did you characterize even in the mice? Because you have shown polybrin sensitivity, you have shown data from transplanted patients with some issues. So I was wondering whether, at least in mice, you have investigated the health of the niche and the features of the stem cells.
No, we didn't. And also for the polybrin, we don't use polybrin obviously for the human, but no, we didn't.